Hello, everyone. So happy you could join us for today's amazing topic. Today, we are presenting on women's heart health, and we're hoping to have a heart-to-heart conversation. We have an amazing lineup of speakers, and this topic is near and dear to all of our hearts. So, really, really excited to share it with you today. For our agenda today, we'll go through our introductions. We'll talk about unique challenges to women's heart health care. And then we'll go through some of our most common questions that got entered. Again, we won't be able to get to all of them. We had probably 300 plus questions asked, and that doesn't even count the questions that we have from previous webinars and the ones that we will get live today. We'll go through the phases of a woman's hormone cycle of their life. We'll go through common arrhythmias and then talk about heart attacks, strokes, and obviously we have to hit on that lifestyle piece. And I always want to point out this disclosure here. These webinars are for educational purposes only. This should never replace the information coming from your personal care team. For introductions today, I'll start off. If you've been to our Kardia webinars before, you've met me. My name is Ashley Triban. I am checking in today from the Columbus, Ohio area, and my background is in health and wellness, lifestyle medicine. I'm a board certified health and wellness coach, as well as a board certified lifestyle medicine professional. My background professionally is in HR with health and wellness benefits, working in employee health and wellness, so keeping people healthy that way at work. And now here at AliveCore, I am privileged to get to work with our Kardia community and adding value to your subscription. So really excited to bring you this lineup today. We'll start with Dr. Rina Bhargava. Dr. Bhargava, could you introduce yourself?
Happy to. Thanks for joining, folks. February, the heart month. American Heart Association has done an amazing job of highlighting the need to address women's health, especially as far as the heart's concerned, differently from everybody else's heart disease and heart health. And so a huge thanks to our whole team, Ashley, Katie, Rosie, Pia, and my colleague, Dr. Daria Gillespie, coming together to welcome you and do what we can. I'm an internist. I'm triple board certified in lifestyle medicine and clinical informatics as well, and co-founder of BioTrax AI. And that's an online platform that will launch really soon for your physicians and for members, for folks that are health conscious to take care of their health with precision medicine, longevity medicine, all the tools needed to monitor and take care of themselves. I was previously medical director and a practicing physician at Kaiser Permanente, taking care of more than 4 million patients in our digital health and telehealth roles. Thanks so much, Ashley. Over to you.
Thank you. And Dr. Daria Long Gillespie,
Hi,
please introduce yourself.
thank you so much, Ashley. And yes, I'm thrilled to be able to join all of you. I am an Atlanta-based board certified emergency medicine physician. I work clinically in a separate a pediatrics emergency department and separately in an adult emergency department. I'm a mom of three, and I am the founder of No Panic Parenting, where I help people prevent accidents, illnesses, and emergencies, and also know what to do when they happen, including how to handle CP, how to do CPR, choking, and other emergencies like that. I'm also a clinical assistant professor at the University of Tennessee and an instructor for the American Heart Association, and regularly go on television and social media, helping people understand how to prevent illness and how to keep themselves healthy.
So if she looks familiar. And Katie, if people have joined our webinars before, they've met you as well. Go ahead and remind folks who you are.
Yeah, hi everyone. I'm Katie. I am a product manager here at AliveCore. I focus on our Kardia app and some of our clinical tools as well, and our signature Kardia Care membership. So excited to have over 270 of you live on this call to talk about this really important topic. I will also take a moment to introduce Rosie and Pia, who are on the call to help us with Q&A. we'll be trying our best to answer your questions as we go along, and then also asking some of your questions live to our doctors. A couple things to make you all aware of from a navigation perspective. On the bottom of your screen, you should see a Q&A box. You can tap that to submit questions to us as well as to review questions that we have answered. So that's a really great tool to engage with this presentation. Also, I see a couple of you already using the reaction tool. We have that as well on the bottom where you can send us a reaction if you are loving the content. Look at that. We're seeing a lot of hearts, which is perfect for this heart month and for all the red that we have wearing today. But yeah, please continue to send that. We do look at them and we see how you're engaging with our content. So thank you in advance for engaging with us.
And with that, we will dive in. So, talking about the women specific challenges in our healthcare system. I want to read this quote for you on underrepresentation. Historically, cardiovascular clinical trials have underrepresented females, but findings have nonetheless been applied to clinical care in a sex agnostic manner. Basically, summarize this, it's saying that while mostly men have made up our clinical trials, uh, for anything from drugs to treatments to procedures, they've been applied to men and women equally. Now we know, and we will see in this presentation, how different female bodies are. Dr. Bhargava, would you like to weigh in on this idea of women being underrepresented?
Thanks, Ashley. And that is so true. That's probably not news to folks on this forum. We've heard about that in lay literature. And, women were just not invited to the table or to the research studies for the longest time. And if you kind of count out those numbers, it's only about 40% of participants in cardiovascular clinical trials that are women. And we're definitely not 40% of the general population, we know that. And yet, cardiovascular disease is the leading cause of death for men and women, and particularly so, women are underrepresented in acute heart attack kind of situations, acute coronary syndrome. Only about 30% of those were done in women. Heart disease, anywhere in the range of 24 to 30 some percent. Heart failure. The story goes on. Nothing unusual about that. And yet, what is interesting is that the results from those studies are applied to women, as though they were men, as though, the physiology and everything else was exactly the same. We're not. We are the difference in how our endothelium, the inner lining of those blood vessels, behaves. The difference in ages when we present, whether we have diabetes and a much, much higher risk of heart disease, that, how drugs react for women are really different. And then guideline-directed therapy also was built around men. So overall, there's a lot of ground we have to cover. I actually did a gender bias lipid management study, you won't believe it, close to 2 decades away, and presented at the American Heart Association meetings. And the gap was significant. We knew what we had to do. We had the tools and patients right in front of us. We missed the mark. So this is nothing new that we're highlighting, and yet we're behind. So thanks, Ashley, for highlighting this really big issue.
Thank you. And also, I think the other takeaway, women are not small men. I love to highlight that because it sounds so arbitrary, but it is how things are measured currently. Hopefully in 10 years, 10, 20 years, we can have less and less of these conversations.
There's one, sorry, Ashley, I'm going to add one comment because this group of folks knows or most likely is tuned into cardia, atrial fibrillation, and how it presents a little bit differently. And we do want to reinforce that story is absolutely true for atrial fibrillation as well. We women, the way our heart electrical system works, by and large, a tiny bit slower. especially when we're older, we're much higher risk for atrial fibrillation, all of those kind of factors. So there's a significant difference in how that presents and how it is managed. Over to you.
Thank you. And yes, I learn something new every time we go through this deck. And talking about undertreatment. So not only are women underrepresented, but then undertreated. That idea of, there's a lot of caretaking, but also just, busy, busy, busy. And are women going for treatment when they need it? And then are women getting the treatment that they need when they need it? So reading this quote to you. Women are underscreened and undertreated, especially postmenopausal women who have a barrage of new risk factors that many are not even aware of. So, Dr. Gillespie, if you could weigh in on that.
Yeah, absolutely. And I think Dr. Bhargava made some fabulous points on the research and research into treatment and the pathophysiology for women. I think there are two things that often lead to a delay in seeking care when it comes to women. And one you kind of alluded to, Ashley, it's kind of behaviorally. Women we're caregiving, we're taking care of other people, we're thinking about a lot of other things. And a lot of times our own health gets pushed a little bit to the wayside. It's one of them. A second is actually, again, the physiology of our symptoms. And, as Dr. Bhargava mentioned, since we represent a much smaller percentage of the studies that were studied to classically define, the crushing chest pain you're supposed to have when you have a cardiac event, women's symptoms themselves, just like our pathophysiology of it, our symptoms are different. Women are less likely to have that very obvious crushing chest pain, the fist to the chest, the cold sweats, all the things that men might have. We see this a lot in the emergency department, and the symptoms may be more vague. I might have a patient that comes in and her symptom is primarily exhaustion. She says, I am just so tired lately. I don't have the energy. And a lot of times they track it up maybe to a poor diet, maybe they eat some tea and toast and just not eating very well. So they chalk it up to that because it's vague. Maybe it's fatigue, I mentioned. Maybe it's just nausea a lot of the times. For the last 6 weeks, I just am constantly nauseated. And again, it's not a specific symptom. It's a subtle symptom so that it's easier to ignore as well. And maybe sometimes we're talking about a little bit of shortness of breath and difference like that. But those two things combined with maybe our potential to ignore our symptoms in the first place and the fact that since they are less studied, they are less discussed and less obvious also lead to delays in treatment. So often you're not finding out until the person has had this heart event for a while.
And I love that you brought that idea of self-silencing up because that is where we are headed next. Talking about women and self-silencing and caretaking. So, how women express themselves and assert their needs may be related to their health. In some relationships, such as in a relationship where there's greater power differential, women may learn to self-silence or inhibit one's feelings, thoughts, or actions to avoid conflict or loss of relationship. I raise my hand on this one because I can't think of how many times I've been told either to bite my tongue or or I do it myself to avoid conflict. And so, Dr. Gillespie, if you would weigh in on that, just elaborate on kind of what you were talking about before.
Yeah, I think that's very accurate. I think women, as we go, for one, we've also been told that men are at the higher risk of having cardiac disease. Again, that's kind of like the standard story that we were told. And so women are, maybe they're less likely to try to seek care that way. Their symptoms, again, are less likely. And they're vague and maybe they've just also gone through, they're now postmenopausal and it's a lot easier to say, well, maybe this is all just due to that and to write it off and maybe they don't want to bring it up or somebody might say it's because you're now postmenopausal, things change. And it's hard then to say, hey, yes, that is true. And I think there's something else is also going on that I'd like to be checked. And I know that's what we're going to be talking about today is giving your viewers that language as well. I always try to say that. Here's what to look for so that you, when you're talking to your doctor, if we can be using the same language, then your doctor can, be better teed into what you need.
Beautifully said. That idea that we can both speak the same language and hopefully assert ourselves and get validation. So we're going to dive into a very a very high level conversation around your heart and hormones. Again, you could go and get an entire medical degree on this, but we are going to do a crash course today. So I wanted you to understand the common terms that you'll hear us speak about today. As we talk about a woman's life cycle, we're talking about a woman in her menstrual phase. Most women will get their menarche or first period between the ages of 11 and 14. And then this phase will continue through perimenopause. Once someone is perimenopausal, that transition usually starts in the mid 40s in the United States. And this is a transitional phase. So you'll also hear us say menopause transition, describing perimenopause. As we get into menopause, menopause usually, on average, it has an onset of around 52 years of age in the United States, and then is defined as a 12-month consecutive time frame without a period. Therefore, menopause is actually a moment of diagnosis, not a stage. So I know in the United States we say menopause and we are mostly talking about post-menopause. So I just want to stress that if you hear menopause or post-menopause today, that will be after menopause. And then you can see post-menopause over here. This is the rest of a woman's life. And this is where symptoms should start to or can start to lessen or go away. And then you'll learn in a little bit why this increases our risk of heart conditions. And I wanted to show this graphic just because I know, again, when we talk about underrepresentation, we talk about undertreatment of women, and we talk about self-silencing, that idea that I hear women in health coaching all the time, women that come to me for health coaching, they'll say, something's not right. So I just, things are all over the place. I don't feel like myself. And I wanted this graphic on here to show you that there is validation in that. There is actually something happening in your body. And to, give ourselves some grace and be kind to ourselves that we're going through this. And you can see here we've outlined two of the main culprits in the hormone conversation in heart health. Estrogen, where you can see in the graph here that this peaks around mid-cycle, and then during pregnancy there's a rapid decline in postmenopause, and this is what leads to that CVD or cardiovascular disease risk factors. Also, it creates a pro-arrhythmic environment, and we'll get into that as we talk about arrhythmias. Now, for progesterone, you can see that it peaks toward the end of the cycle, and this causes an increase in sympathetic nervous system activity and resting heart rate. We did see some questions submitted. Why do I have a higher resting heart rate? Why does my heart, feel like, 5 years ago, 10 years ago, my resting heart rate was 60 beats per minute, and now today it is 70 beats per minute, things like that. You know your body and you know there's something that's changing, and we'll discuss that a little further as well. But this increased sympathetic nervous system activity, other things that are associated with it is the feeling of anxiety, shortness of breath, a lot of the things that women will say that they're feeling and not be able to quite put their finger on why. And then all of this lowers the threshold for PACs. So I want to talk about PACs and PVCs in a little bit as well. Okay, and first, again, we'll talk about those phases. Our first one is the menstrual phase and of a woman's life, and how can hormones affect your heart during that phase? Dr. Gillespie, I'll hand it off to you here.
Wonderful. Thank you, Ashley. And yes, as you remember from that graph earlier, I remember that's something we all had to learn in medical school. But the important part, if you remember those red and blue lines, estrogen and progesterone, fluctuating throughout our cycles, throughout our life when we are, between puberty and premenopausal. And then there is the perimenopausal stage. And then, of course, there is the postmenopausal stage, which is when those hormone levels have really dropped. And that is, I mean, as Ashley noted, it's what makes it hard. And what is what makes it very hard for women at this stage because just the standard natural cycle of fluctuation of our hormones can cause things to change, can alone cause our blood pressure to be a little bit up and down, our heart rate a little bit up and down, our overall symptoms a little bit up and down. So that's always happening as we all know during our cycles. But then when you hit that perimenopausal stage and the hormone levels start to be withdrawn, then that triggers both symptoms which could maybe just be attributed to the hormones, but also that absence and withdrawal of symptoms, as noted here, increases your risk also of arrhythmias, of heart disease, of this blood pressure dysregulation and hypertension and inflammation, which is all that to say to women that yes, sometimes the symptoms that they're having are part of perimenopause. And sometimes I'll have a woman come in and we'll kind of check for stuff and say, this is part of perimenopause. And sometimes for her, she's like, thank you for just telling me I'm not losing my mind. This is part of perimenopause. And also, often I will still say, I still want you to go see a cardiologist, as somebody who will be able to evaluate you and make sure that there's not more going on, because that fact of being in perimenopause and postmenopause will put you at higher risk. So it's kind of this duality that I think is really important for women to notice.
Dr. Gillespie, a couple of questions that came in. So, number one, someone asked in a pre-submitted question, is it normal to get sharp pains or chest tightness around your period? And then how would you recommend treating or preventing that?
So I mean, any good ER doctor, if you're having chest tightness, I would like you to get checked out. There is no way that I can tell somebody over Zoom. So what I always tell, yes, I mean, there's lots of times people might get little twinges or things like that, and but that might be part of the physiology. But in general, if somebody's having chest tightness, I'm going to say at least go the first time. Go see your doctor, get that EKG done, get that test checked, and maybe you'll get checked, and then they'll be able to tell you, okay, this is part of your cycle. But no, I don't expect a woman to come in and say like you are having chest pressure, especially if it has associated symptoms, shortness of breath, nausea, sweats, anything else. If you got associated symptoms with that, I would never just write that off and say, it's just your period, ignore it.
Thank
And
you.
along with that, I always recommend journaling too. Our cycle only comes around, once a month. So journal how you're feeling. See if you can pick out themes and patterns and take that with you to your doctor. So you have that backup to your story.
We may cover this in later slides a little bit, but a couple questions, both from Marion and from an anonymous person. If you have a hysterectomy, are you immediately post-menopause? And then just a question on how does a hysterectomy affect your heart?
Dr. Varga,
Yeah, I
yes,
can take
I see
that.
you
I can
moving.
take.
Yes, go for it.
Happy to take that. Great question. We need to parse out the different parts of our anatomy. So the hysterectomy is most of the time just to remove the uterus. But it could also be where they do this total hysterectomy and they remove the tubes together with the uterus as well as the ovaries. Now, when they're removing the ovaries, yes, it impacts our hormones. And essentially, we go into the surgical menopause, whatever be the age the surgery happens. And that will impact a lot of our cardiovascular health. But if they just did it for the uterus, somebody had some fibroids, somebody had some pathology there, and so forth, left those ovaries intact, then most of the time it behaves, like we're normal. But there are still some differences. Our body does recognize that we're not going through those cycles as much. And so we're not quite the same as we were pre-surgical, but pretty close there hormonally.
I would also note that answer was exceptional. If somebody is having their ovaries removed, as Dr. Bargava mentioned, that is going to induce it. One of the challenges is naturally, if you physiologically go into menopause, you've gone through several years of perimenopause and changes, versus if you surgically go through it. I always say, talk to your doctors who know what to expect, because you're going to effectively, in 12 hours go to this absence of those hormones. So it's a much more drastic shift. So I always say, if you are having that, are the ovaries being removed? And then how can we expect what to do? What do I need to do from that management standpoint too?
Yeah, and Marion actually called that out in her comment. She said she had a hysterectomy 15 years ago and she's still having all the symptoms of menopause.
Yeah. And if you still have your ovaries, then I guess that's what makes a difference. Yes.
Wow. I'm learning. This is great. This is a great conversation that needs to happen. And just to outline a couple of risk factors here, people who have severe premenstrual disorder, people who have it's PMDD or premenstrual dysphoric disorder, and then shorter cycles or longer cycles, they can all put you at a little higher risk for heart complications. Studies are showing.
Yeah, and one last question from Mary. Is it normal for palpitations to get worse during period and ovulation? Also, blood pressure seems to go up during period. Is that normal?
Um,
Go ahead. Go ahead,
Sure. Yes.
Dr.
And I know
Button.
we're going to talk probably a little bit about this in the PVC section, but yes, you can absolutely see fluctuations as your hormones fluctuate. Then yes, and again, that's where Ashley is talking about the journal. Great. Is absolutely wonderful. And if you feel them and you're really having a lot of them, even more powerful is a journal while you're wearing a heart monitor. If your doctor will give you a 21 a day heart monitor, something like that, and we can talk about this sort. But then you have when you have, and we talk about this with the Kardia devices as well, because if you can have symptoms matching to your EKG or telemetry at the time, that's even more powerful to be able to tell and tie everything else in together to figure out what's going on.
Using that Kardia device and also using the health diary,
Yeah.
note taking and tagging that's associated with it. Great plug.
Yeah, I didn't even mean to. There we go. You're welcome.
Well, we started to get into perimenopause, and it's such, again, it's a transition, it's a phase, but so many things are happening in the body. Dr. Gillespie, if you would continue that conversation, just taking us from the premenstrual phase now into perimenopause.
Yes. Okay. And yes, as you mentioned, this can go on for years. And this is constantly evolving. I think it's actually very exciting to the work that is being done here because, as you guys mentioned, it used to be, you thought it was you live your life and then suddenly, boom, you hit menopause and then there's this big sudden change. Then actually, this is happening for several years. So what's happening? Your mid 40s to your mid 50s as that estrogen level starts to decrease, as that progesterone, all those hormones start to decrease. So yes, your blood vessels, as Dr. Bhargava mentioned, the endothelium, which is the lining of the blood vessels of women, is different because of the effect of hormones and the kind of a protective effect of estrogen that we have. But then you start to go through perimenopause, that estrogen level starts to fall, and hence the protective level of it and protective effect of it starts to fall, which is why you have the blood vessels get a little bit stiffer. You also have, as noted here, you have that plaque start to pick up, build up that atherosclerosis, and you have changes in your body's cholesterol, the LDL, kind of thought of as like the bad cholesterol traditionally, and the HDL, the good cholesterol. Those ratios start to change in terms of from being a more protective one to being a less protective. And then you get those hot flash symptoms that everybody talks about and are well known, but even though we always didn't understand the physiology of them. And of course, also as a result of that, may be experiencing some like expanding, it changes the deposition of where our body fat is, increasing it more in the abdomen. So the hormones, these are true physiologic things. It's not in your head. You're not going crazy. Like this is actually what the body is doing as it is adjusting to the withdrawal of this hormones that we've had all of our lives.
I love that you're validating. And I look at this runner on the one side over to the woman who's a little overweight on the other side. And there's something happening in our body, and we can be so hard on ourselves. Even our care team sometimes can be hard on us. I heard in some of the comments, people were saying, my doctor just tells me to lose weight. And it's like we wish it was that easy. So I hope everyone, I hope there's some hearts coming in. I hope that you feel heard and seen with this conversation.
I will also say, I see hearts coming in. One of the things we talk about, you say, and women attributing it to somebody saying, "Oh, your symptoms are just because you have extra weight or going through menopause," and it might be. But also, like one of the things, what I always tell patients, like if you think, and we'll talk about this, but if you think it's your heart, ask your doctor because belly, increased abdominal girth, increased belly circumference is also one of the very early symptoms of heart failure. You often see that before you see the swelling in their legs. So if somebody's coming to me and saying, my belly is, I feel like it's more swollen, more distended. Yeah, maybe I'm just eating too much. And that might be, sure, maybe we all probably could eat a little bit less. And it might be hormonally triggered, but especially if somebody has a constellation of other heart relating sounding symptoms, that's going to be a signal to me that maybe, and maybe let's also check your heart.
Dr. Gillespie, one kind of pivot question here, but we had the question, how do I know when I am fully done with this transition and fully out of this menopause phase?
Dr. Bhargava, I'm going to let you answer that because you have, I know you had the expertise in hormones.
And we're actually going to I'm going to switch the slide to talk about menopause, postmenopause, and Dr. Bargava, hand it off to you.
Hey,
Hopefully you can answer that on the slide.
thanks so much. So yes, it's all about the hormones for women. They play an amazing major role in where we are. And I want to set the stage a little bit about what we learned from a very large study about 20 some years back and where we are when we re-looked at that study to say what role did those hormones play and how did our understanding of overcoming those changes, maybe with hormone replacement therapy, really make a difference. So this was the Women's Health Initiative study, amazing, large, randomized control. It's kind of the best kind of study that we want to look at. But let's face it, even when it's the best, it's not a perfect world because we do different things and you can, we're not people sitting in a lab, or all identical, et cetera, et cetera. We're doing different things. And so what we learned with that study was that, when there was estrogen being used together with progesterone, then there seemed to be an 18% increase in heart disease. Hello, we don't want that. We're doing things to protect people. And there was a 37% increase in stroke. Also in, clots going to the lungs and things like that. So, whoa, let's stop that. And even in the other arm, which just had the estrogen, there was no effect on heart disease, but strokes did increase by about 27%. So for some of the folks that might have gone through menopause in the last 10, 15 years or what have you, you may well recall your physicians weren't talking about hormone replacement therapy. But then our researchers went back to that data and we realized that changes do happen. Hormones are effective, but you got to do it in the right time frame. So somebody who gets started, you go through menopause, you got those vasomotor symptoms. I mean, all of us have heard about that. Hot flashes, what have you, night sweats, just miserable for months and years. Then and if we could start them on that replacement therapy within 10 years or before the age of 60. And this is now being supported by our American Heart Association as well. Now we do good for women, and we should not ignore that. And so, sorry to say, a lot of this teaching was pulled out of the curricula from medical personnel. We weren't just talking about it, and weren't teaching med students about this stuff. But that is an amazing learning. And why, the hormones and what do they do for us? They do an amazing increase, as is noted on this slide, of increasing and doubling the rate of that plaque, the blockage that we start developing in our blood vessels that finally do, cause the block and the heart attack and the stroke. But also there's endothelium, the tiny coverings. That's where estrogen is really, really important. It's kind of anti-inflammatory, reduces the inflammation there. It reduces the clotting kind of properties. It includes it improves the opening of those blood vessels, vasoactive, so multiple functions there. It also has an impact on our cholesterol fractions, LDL cholesterol, ApoB, which is a good marker, a separate and a good marker. And here you see the LP little a, which is something we're born with. But there's an interesting, amazing increase by 25% for this amazing, biomarker of our health, of, of our heart health that goes up just because we went through menopause. Blood pressure goes up again aggressively. And so these are things that we need to start watching for. Our body composition shifts, just like Dr. Gillespie was talking about. So it is more, all of us know that we struggle with that fat around the middle. Oh my gosh, you can lose it everywhere, but not around the middle. And that's the worst of the fat, because that's the one what correlates with metabolic syndrome, with heart disease, with prediabetes, risk for diabetes, all of those factors. So there's so much happening at this stage beyond vasomotor functions that we can tell beyond, I stopped having my periods, or they're irregular, or now for 6 months they haven't. So we can check for FSH, LH levels. And I will say this, between Dr. Gillespie and myself, I'm an internist, she's the ER physician. We're not, you know, gynecologists and hormone specialists, but this much is kind of well validated. We need to make a significant change for what we're doing, how we're doing, work with your physicians or your gynecologist to make sure we optimize your hormonal health, which is related strongly to the cardiovascular outcomes.
Dr. Bhargava, I know we need to get moving on the presentation, but a couple of questions. There's a lot of people who are following up about the first box, this plaque progression. Um,
Yeah.
the questions that we have, I'll just read two of them. One
Mhm.
from Judith. She says, the plaque progression is puzzling to me. Are statins causing an increase in plaque progression? I was told it would decrease the chance of heart attack, help cholesterol and associated levels.
Absolutely. No, statins are our big friends. Statins are not causing this. It's our hormones that are the hormonal changes, our bodies changing in any case. Plaque starts developing even at very, very young age. I mean, if you studies done in young children have noticed tiny spot plaque in their blood vessels. Happens for men, happens for women, but there's something that happens around menopause that this again accelerates. So statins actually lower the speed of progression of the plaque. It's an amazing medication. There are a few others out there. There's also anti-inflammatories because inflammation seems to play a role here as well. Markers for that, biomarkers like hsCRP. So between the LDL cholesterol, the ApoB, the LP little a, newer markers that we are understanding and now bringing into clinical medicine that we can do better and absolutely stay with the statin for most of our patients. It's well tolerated and really makes a difference.
So you're saying that there may be a more optimal care than just statins, that the statins might actually be working better for the men. And with our challenges, we might need some more exploration, some more something to go with those statins,
That's individualized treatment. A lot of
individualized.
our patients can be managed effectively with statin as well. Oh, and depending on who the patient is and where they are in the whole scheme of things, our goals for LDL cholesterol will change. And so, in a very high risk patient, we might want to get that LDL cholesterol with the help of statins. So, we've got some amazing ones who Crestor, rosuvastatin does an amazing job, and you can bring the LDL cholesterol lower than 70, and you're like, okay, let's keep going. But if it does not, yes, we have complementary medications and ezetimibe. There are other inhibitors that can be added on and make a difference. Thanks,
So
Ashley.
well put. Thank you.
And then I have one other question to get to. Someone asked, what if you have never been pregnant and you're postmenopausal? Does that impact your cardiac risk?
I am not aware that pregnancy protects us from cardiovascular. I've not come across that data. Um, and we have had a lot of studies in this area. So I don't believe so. I'm gonna check with Dr. Gillespie if she's heard any or read anything different. But unfortunately, no, having kids doesn't particularly protect you in the postmenopausal stage.
No, and I think you're exactly right. And if we look at the physiology, pregnancy is kind of a 40-week stress test. So it changes it, but I agree with you. I've not seen anything that is protective per se. And sometimes people hear like things for like breast cancer and different things, ovarian cancer, there might be the impact of pregnancy and the hormones in, but I don't see anything. I've not seen that for heart.
Right. With that, we're actually moving into our conversations on arrhythmias and hormones. And again, you don't have to go get a medical degree, but we're going to give you a quick anatomy 101 of the heart here. You can see the four chambers that are listed. You've got the right atrium, the right ventricle, and then up you've got the left atrium and the left ventricle. Now, what we're really going to, those are the chambers of the heart. And what we're really going to be talking about when we talk about arrhythmias, these yellow lines here that are all listed. We're talking about the electrical currents of the heart. And these are what fire and help the heart to contract. And we know when the heart contracts in these different areas, that's how the blood flows through the heart and then out to the rest of your body. So that'll be the conversation. We talk, a lot of comments came in about, or questions came in about testing. You can always think that with an echo, they're measuring, the chambers of the heart, the structure of the heart, those different things. When we talk about an EKG or when you take a Kardia reading, we're actually looking at the electrical currency of the heart and how things are firing there. So diving in to talk about PACs and PVCs, a very popular topic. We have done an entire webinar on this topic. Again, that was a male, female, everyone in general. We will include that link in our post-session email. But Dr. Gillespie, if you would give us kind of an outline of PACs and PVCs, and any other insights.
Yes. I like to explain this when I do this on social media, on TV. I think of your heart kind of like your heart's like this orchestra. And as you saw from Ashley's picture, your SA node, the sinoatrial node, that is your conductor. That is telling people when to beat. Now, a PAC is when the conductor, or maybe somebody right around the conductor, gets a little excited and they tell everybody to beat, and everybody kind of beats, and it's just faster. Everything happens a little faster. A PVC, on the other hand, is where instead of your conductor telling somebody what to do, your drummer or your tuba or your oboe, somebody, aka in the ventricles, plays something faster. And what happens when you do that, you have that early beat. So the analogy in the orchestra, somebody plays something faster, it feels faster, and then everybody's kind of shocked, right? The rest of your orchestra pauses for a second because they're shocked that the oboist just went rogue. They wait, and then they reset and they go. And that's what happens with a PVC. So some other aberrant, not the conductor, part of your heart in the ventricles beats. And when it does, first you feel that. You feel like this big beat. It feels like a little wrong often because it's kind of the blood pressure is going and the blood's going the way it wasn't really directed to go. So you feel that and you feel that pound. And then sometimes people feel that. But then sometimes also, as I noted, the orchestra pauses. Similarly, your heart pauses for a second because you had this earlier beat than was supposed to happen. And so your heart kind of resets. There's a little bit of a pause. It's a little bit longer than your normal beat to beat. So sometimes people feel that. And then the heart kind of whooshes back together and everything beats again. So those are three different strange phases. And a lot of people feel different ones. They may feel that first push, they may feel that pause, or they may feel that kind of rush at the end. That's what a PVC is. And it can feel very uncomfortable to people. And I know we're going to be talking about the symptoms but also just to talk about in general, how common are these. So there was one statistic that I had read that if you look, 32% of people, I apologize. So 70% of people will have about under what's under considered a 1% PVC burden. But really the reality is if you monitor, 6% of people, if you monitor them just for 2 minutes, they're going to have a PVC. 40 to 80% of people, if you monitor them for 24 hours, are going to have some PVC. So PVCs are very common. The issue is not the one PVC. The issue is the regularity in which you have it. And that's kind of how we think about it. Is somebody just having one PVC a day or once every other day or something like that? Or are they having, 20 PVCs or in a row in a minute? Very different. And so that's kind of one of the ways that we tend to kind of stratify them is how regularly you're having them. Less than 1%, 1 to 5%, above that, the degree of PVC burden. Now we'll talk about also important to talk about the causes. So we talk about age, and it is age just overall, the age of your heart and that that conduction system and that was the yellow picture, but also as we've noted, age and hormones the hormone changes that come with that age put you at higher risk of PACs, PVCs, and that irritability of the heart, making it more likely that it'll have these extra beats. What other things do? Alcohol, caffeine, and other stimulants, even cough and cold medications may do it, and other stimulants, of course tobacco as well, which I consider a stimulant. Stress and lack of sleep, a lot of people may notice that when they're not sleeping or when they're stressed they feel these more. Of course underlying health conditions and can make this more likely, and there's those medications and decongestants. I talked about the symptoms as we mentioned, that fluttering, pounding, you feel it skipped or extra beat. Sometimes you feel this, you maybe not feel it all day long, and then you're laying in bed. Anybody ever laying in bed and then they feel that boom beat in their heart and you're feeling it then. And then in terms of treatment, again, it comes down. Oh, we got a lot of thumbs up. We got a lot of people who put their I will say one of the things, and that I've been talking to cardiologists and all, they tend to say, if the only time you're feeling is when you're laying down at night, that's actually a good thing. It means it's not so bad that it's disrupting your day. But yeah, you're laying at night and, thinking through your day and you feel that. So in terms of treatment, again, it comes down to the percent of burden. So if you are having just very irregular and but it's bothersome because they are bothersome, we'll start with lifestyle treatment and all those things in that left corner. Can't change the age one. So, aside from that, a lot of those are very modifiable. And I'll talk to patients, so, how often are you doing these things? And some find that they're very sensitive to certain things and triggering, and that's where your journal can come in as well when you're trying to figure out what they are. In terms of, switching, yes, supplements are listed here, magnesium, because one of the different things that can trigger PACs, PVCs, one of them is low potassium and low magnesium. So if somebody's actually low magnesium, then yes, that can help. Magnesium is also a muscle relaxant, so it can help in that way. In terms of medication and catheter ablation, that's when you're seeing your cardiologist, you're wearing a monitor, and they're going to start to count like what is the amount of burden you're having per day. If it is sufficient, that it's either, if somebody's very, very symptomatic, or it's enough that, if somebody's having many, many, many per day, it can over time cause a cardiomyopathy. Then you'll have the discussion of medications and eventually ablation if they can't get them under control.
Dr. Gillespie, the only question I'm going to ask you on this has come in both pre and someone asked in the chat right now. What is that burden that's concerning?
Yeah. So that's a great question. So in general, under 1% is felt to be normal. So what's 1%? If you think about it, if you say you have a resting heart rate around 65 beats per minute, so that's about 3,600 beats per hour, and about, according to the day, you have about 100,000 beats a day. I mean, go heart, 100,000 beats, like that's crazy. So 1% of that is 1,000 beats, or about 42 PVCs per hour, which to a lot of people that might actually feel like a lot. That's kind of under that. It's felt that it's safe. It's not going to cause any degree of heart damage. That said, I'll say if somebody is feeling them regularly, that's when you wear the monitor, go to your doctor. They can actually calculate that and see, try the lifestyle changes and start to see if it's time for an intervention. But I will also say if you have these, wear a monitor because there's no way to count them otherwise. So especially if they're happening while you're sleeping and different things, and you want to know that. So one of those 21-day monitor is the very best way to do that.
And if you're taking those Kardia readings and getting PACs or PVCs, make sure you're using that note-taking piece as well and tagging those. And Katie, there is that note at the bottom here that Kardia Care members, the determinations, the advanced determinations that you can expect.
Love it.
Okay, and then this was huge when we talked about PVCs and PACs, but stress. And we'll actually talk a little bit more about stress in our lifestyle area. We have to speed up a little bit for time, but just know that our hormones make it difficult for us to process stress. We as women process stress differently. We'll talk about that in a little bit. But obviously, that doesn't hurt. It doesn't hurt to build up our toolkit. So we can set boundaries, we can taper expectations, maintain a routine, be present, and then also manage our stress. So moving into atrial fibrillation, again, another topic that we have done an entire webinar on all about AFib, and we will include that link in our post-session notes as well. But Dr. Bhargava, walk us through atrial fibrillation.
Hey, thanks, Ashley. And so lovely hearing everybody. Great job, Dr. Gillespie, going over the PSCs and PVCs, irregular rhythms. Those are solitary, they happen one at a time. So, what is atrial fibrillation? It is irregular. You've heard about this for the longest time, and sometimes you have these celebrities or somebody go through that. The first time I remember was George Bush, who had it, and he had senior, and he had more caffeine. So essentially, about 2 million folks in the United States have atrial fibrillation, not rare at all. And what that is when the heart rhythm just goes nuts. It's irregularly irregular. That's what's happening. It's happening at a constant pace for some people when they're chronically in atrial fibrillation, but they can also have it what we call paroxysmally. Just happens for a few seconds, for a few minutes, maybe an hour or two, and then, settles down. And some of that we may know about, and some of it we may not know about. So the difference there is that if we have that atrial fibrillation, means the top chamber of the heart, the atria, are firing irregularly from different parts, not just from that main major node, the sinoatrial node. And then if the transmission down to the ventricle, which is really where we feel that heartbeat, is good and strong, we're going to feel it a lot. It's not that good, not that strong. We won't feel that, which is kind of nicer. But any case, it does increase the risk for a number of things for us. And we do want to be aware when we're in atrial fibrillation. And one of the major presentations might be palpitations, like we've been talking about with the PSCs, PVCs, but those are episodic, just, one or two at a time and then gone. This is more regular. And so we really feel that short of breath, tired, maybe really lightheaded, maybe having some chest discomfort. And that definitely requires us going to the emergency room, getting checked out. Because we don't want to run the risk of having the heart run so fast that it's not providing enough oxygen to our brain and other parts of the body, etc. So the common episodes listed here, a lot of alcohol, smoking, yes. That decongestant we might take, pseudoephedrine, not the one that you can buy easily, that's sitting on the shelf. The phenylephrine, that decongestant is actually not worth the money, and it does not speed up the heart as much. But the one that the pharmacist keeps behind the counter, and you got to show your driver's license for that, that's an amazing stimulant. So you got to be careful with that. If you've had any, irregular heartbeats in the past, definitely want to avoid that. Lack of sleep issues, caffeine's a big one. Dehydration, stress, hormonal changes, definitely. And, the tools we might have so number one, we got to identify what this is. Because we might think a heart skipping beats, but maybe it's just PACs, these, reasonably benign ones. versus atrial fibrillation, which needs more work to be done. So your Kardia device is going to be really, really helpful to help identify that. And especially journaling your symptoms with that, that's important. So the procedure, if you go into the emergency room or go to the cardiology office, they can do cardioversion, or there are medications that help with that to abort this atrial fibrillation. And then there's also particularly the vagal maneuvers. So our vagus nerve is the parasympathetic nerve. It's the one that slows the heart rate down. And you can do some maneuvers like bearing down or putting cold compress on the face and neck, somewhat easy to do, that can abort this. But any case, if it's going on, your heart's going fast, you're heading to the emergency room. You're not taking a chance. In the interim, though, you could try these slow breathing, yoga. You'll be panicking so much, but most of all, these vagal maneuvers are actually what we oftentimes train our patients to do while we're waiting to sort out, get an EKG machine, really validate what's going on, and so forth.
All right. And we always call out this, when to go to the ER with AFib. So I wanted to call that
Yeah,
out. We are running
that's
short
I
on
I
time.
will also note, Ashley, a lot of my patients that come in the AFib with into the ER don't realize they're in AFib. They just felt really lightheaded, very dizzy, very unwell, and we take we're like, oh, it's good. Well, your heart rate's going 140, 160, whatever beats per minute. They didn't know. We have no idea when it started. So another medical plug for like having your cardia and pulling it out if you feel that way, because if you find out that you're AFib, then you're coming in to see us. And that's information that's so helpful to know as soon as somebody's going into it.
Very validating too. Okay, so now we're going to dive in with a couple minutes we have left, heart attacks and stroke. So going over the heart attack symptoms, Dr. Bhargava, can you weigh in on what females should be looking for around heart attacks?
I will. And I'm looking at the time. I think we have 3 more minutes left in this session. So I'm going to zip through this. The one pearl, the one essential piece we want you to leave with is the fact that if you're not sure what's going on, if you've got that elephant sitting on your chest, of course you're calling 911 and you're coming in. No, man or woman, who cares? If you've got chest pain of any other sort that you can't explain, you're feeling crazy dizzy, you're feeling short of breath, fainting, of course we're coming in. But if there's some sense of discomfort, indigestion, nausea, vomiting, that's where, and we also have silent heart attacks for women, more so than men, especially if they're diabetic. So there's a number of things we can cover about that. But yes, if you're not feeling well, connect with your physician, and if and reach out for help.
Unexplained nausea or fatigue is what I hear.
So true.
Yeah, and Dr. Rena, one question for you. Richard asked, are there reports on more men have heart attacks, but more women die because they do not recognize the symptoms? Is that accurate?
Yes, yes, mortality rates are higher in women, absolutely. And especially so when they're older, especially when they're diabetic, those numbers are very different. And yes, so women are higher risk, one, because they present atypically. And sometimes we also have the silent MI, which carry the same cardiovascular risk and the same morbidity, same risk for all of the negative outcomes. We didn't even know about it. An EKG, done maybe 3 days later, 5 days later, would say, oh my, and then you do some blood tests to say, oh yes, you did.
Yeah. I agree. I love Dr. Bhargava's point, and I think that's a great place to close. Is it when in doubt, like your symptoms will not be able to tell you if this is AFib necessarily or a heart attack or anything else. The way to do it, come in and go see Dr. Bhargava and her colleagues, come into the ER, see myself and my colleagues. The only way to tell, you get that EKG, you get the labs. We might need the echocardiogram, things like that. I'd much rather my patients err on the side of that and saying, I think I just want to make sure this isn't my heart. And that's how we can check and do the best care we can for you.
Such a
And I know you have to hop out, Dr. Gillespie. We've got a
Bye.
very, very busy panel here today. But if you want to weigh in on anything with strokes before you go.
I think this is great. There is the face or anything drooping, weakness, difficulty speaking, speech difficulty, trouble walking, lack of coordination. All those things. Time is brain, time is heart. If you have symptoms, don't wait 3 weeks. Come in to see us and let us diagnose and treat as quickly as possible. So,
Oh,
thank you
great.
so much for having me. I am so sorry to have to run. It was such a pleasure.
No, we appreciate your time. Thank you so much. And Dr. Bargava, anything that you want to add about strokes while we're on this slide?
I think it's well covered. Again, anything atypical, yes, there's Bell's palsy that gives a presentation that's somewhat similar, but then that's just the face. Early on, you may not know if that's something as simple as Bell's palsy or a stroke. So when in doubt, reach out for help. No doubt about that. Better safe than sorry.
Better say,
So,
better embarrassed than dead is what I always say. But the
doing
4 and 5 strokes are preventable. We're going to dive into a quick conversation on that for anyone who can stay on. But yeah, Dr. Bhargava, let's talk about lifestyle pillars. We know a healthy lifestyle is important, but when we have these lifestyle factors go the wrong way, go south, for men and women, it can be a very different consequence.
So I totally agree with you. This whole science of lifestyle medicine and lifestyle pillars, probably, we kind of always knew, got to eat right and so forth, but we we were lacking the evidence, stuff that we want proven beyond doubt that what we're saying is the right thing and how much of it is the right thing. And there's a whole um, branch of medicine that came along of lifestyle medicine, and we can get board certified, and I'm board certified in that. And they're really kind of drilling down to beyond medications. There's this basic layer. So there's 6 pillars of lifestyle medicine that we particularly talk about: nutrition. And so a lot of that is the Mediterranean diet. I'm just going to coalesce a few of my talking points because we're short on time. Mediterranean diet or DASH diet that you've heard about, and basically kind of watching the salt as well as monounsaturated fatty acids, olive oil kind of stuff. Physical activity, 150 minutes to 300 minutes of moderate to severe aerobic activity. That's what we want to do. In women, I would add, though we hadn't made a big deal about it in the lifestyle medicine pillars, is adding strengthening exercises. And as we get older, especially flexibility exercises, that is key. One of the biggest risk factors for broken bones is not only osteoporosis, but the fact that we fall, right? And so it's physical activity, aerobic as far as the heart goes and so forth, but that strength training that really builds up the muscle and improves our metabolism, improves that pre-diabetes, diabetes kind of a picture. Substance use, yes, smoking, drinking. I mean, if we quit smoking, within 24 hours, we see a significant change. Our endothelium, that thin layer inside the blood vessels, that starts improving. Social connections, so huge. Our previous Surgeon General did a really good job by highlighting the fact that social isolation is a very big piece, and there's a lot of that, around the world. And that's something that we can make a difference, and it impacts our physical health, our emotional health, etc. Sleep. What seems to be the right time frame is about 7 hours of sleep. Not too much, not too little. More than 9 hours, not a good idea. Less than 6 hours, not a good idea. It affects our metabolism, affects our stress levels, and so forth. So keep that in mind. And overall stress, yes, it gets our heart going. It stresses literally every part of our body, and so forth. So those 6 lifestyle medicine pillars are really key. And I don't know how many more minutes, Ashley, do we have on this, but let's maybe just get to American Heart Association's Essential 8.
And we can actually, so this is the kind of prescription that's out there for heart for cardiac care right now.
Yes.
And I think the best thing to say too is this isn't the diet for diabetes, the diet for this, the diet for that. It is the one thing that if we can live this lifestyle, we can control most chronic conditions. Um, and so what we'll do is we'll actually include a link to the American Heart Association Essential 8 recommendations.
That's awesome. This is really key. Thanks so much.
And as we sum things up today, we always end with this slide. You spent an hour with us today, an hour plus now. Thank you. And we always want to make sure that your time here was well spent if you can save your life or someone you love. I did highlight in yellow these different things that we talked about today that were female specific. Remember that general weakness and that nausea we talked about. And if you can't think of a reason for it. Again, with that journaling and other things, you've been nauseous for a week, but you don't have a culprit. You don't have a reason. Go get checked out. And then the AED symbol up here at the top. Being out in public, knowing that symbol, knowing where it is in airports and restaurants can help you save a loved one or a stranger. With that, we always do end with our Kardia support. If you're having any questions or concerns with your Kardia device membership, anything like that, you can always reach out, and we will include that as well in our post email. I can also include our links on how to stay in touch with our speakers from today. If you heard something you like and you want to learn more, we hope you will check them out. Thank you so much, everyone, for joining today. It's been such a great topic and with amazing speakers. Thank you so much for your time.